Thanks very much, Rod, and thanks for the invitation to speak. It's always a privilege to speak at this meeting, given the calibre of speakers that we have, and this year's certainly no exception. Some disclosures, basic medical advisory board work in clinical trials and stuff, but the content of what I'm going to be talking about today is all my own. And just to sort of frame where we're up to, a few years ago, if we'd given a talk about RSV, it would have been, we don't really know what's going on, we don't really have much we can do for it, so let's talk about flu and then COVID. But obviously that's changed, and how we use all of these interventions continues to change quite rapidly. So I'm going to try and give an update of what the current state of play is for older adults in particular. The outline looks pretty detailed, but a lot of the background I'm going to go through fairly quickly because a lot of people in this audience know that already. You'll have access to these slides later, but perhaps most importantly, I'm afraid of what Rod will do to me if I make us run late. I'm going to focus very much though on obviously the RSV vaccine and its use in older adults. So a little bit of background, again, I think people in this audience mostly know this, but just to point out a little bit about the virus, there are two main antigenic subtypes, A and B, and that's relevant because one of our vaccines for older adults includes both of those. And of course, the major surface proteins is a G and an F or fusion glycoprotein. And again, that's important just to understand because that's the target of all the interventions we're hearing about, both for infants as well as for older adults. And it's not a new virus as opposed to some of the opinions on social media that we made this up to keep talking about stuff post-COVID. It's actually been around since the 50s, and it's not like we just started thinking about interventions. There were some challenges, obviously, along the way that I'll cover very quickly. We've heard about the burden of disease in young children already, but it's also a significant burden in older adults, and that's what I'll focus on. So just flying through the epidemiology, and we've heard some figures on this already, over 30 million cases. In Australia, we had very little information until it became reportable fairly recently, but even the old data, which was fairly limited, suggested it was a significant burden, particularly in terms of hospitalisations and even deaths as well. And the seasonality is a little bit interesting, less relevant for how we use the vaccines in older adults, but has certainly framed how we use some of the interventions for young children. And just looking at the raw figures, and we've heard a lot about some of the other viruses, but we've had some pretty big RSV years as well, with over 170,000 cases in the last 2 years. And if we look at what happens year on year, you can see usually the peak is in around June. Last year, perhaps a little bit later, but a fairly predictable seasonality. But as I say, slightly different in the more tropical parts, in the northern parts of our country. And if we look at positive tests, you can see the axes are fairly different here, so nowhere near as many cases as flu and COVID, and perhaps a little bit later than the peak of the flu season last year as well. Notifications by age, so the bulk of these are in young children, but you can see they do start to climb again once people reach the status of being an older adult, with a significant burden of cases in people over sort of 40s and 50 years of age. If we look at admissions last year, interestingly, you recall I showed that we probably had more cases of COVID than RSV, but if you look at the actual, as an indication of severity, admissions with severe respiratory infection, RSV did account for more of these than COVID last year. Obviously, flu dominated by far. And further indicator of severity, if we look at ICU admissions, you can see a bit of a mixture there. Obviously, flu is the main one, but a significant number of ICU admissions with severe respiratory disease attributed to RSV last year as well. And just to break those down by age, you can see the bulk of those are in young children, but a very significant proportion of those occur in older adults, and RSV and the sort of light green colour there contributed a significant amount of these, obviously behind significantly the flu. And a significant number of deaths as well. These have climbed the last couple of years, about 350 last year, and you can see in July alone there was, I think it was 40, I can't read that, but about 43 deaths, I think, in July alone last year due to RSV. So some people argue, why do we need to do anything about RSV? But you can see hopefully that the burden is significant, and it certainly warrants us trying to step up our interventions. Just to touch very briefly on some clinical elements. Healthy adults less than 50 years of age, and when I plugged a fit and healthy adult less than 50 into Google Images, you can see what came up there. But we get RSV a lot, we probably don't even know about it, probably don't get tested, so very much an underappreciation of the number of cases in that demographic. But once you do get a little bit older, and immunosenescence and other factors, accumulation of comorbidities, etc., it does become a very significant pathogen in terms of burden. And if you compare it to flu, and there's a lot of caveats to some of these comparisons, similar risk of hospitalisation to the flu, but higher rates of functional decline and readmission than the flu. When I looked after a 90-year-old lady last year, went to ICU with RSV, didn't return to her same functional status even out to a year after that admission. And mortality in heavily immune-compromised individuals, very high. You can see their stem cell transplant recipients, mortality 70% or greater. And as I mentioned, about 350 deaths last year, up from about 315 the year before. Risk factors will be well known to many in the audience. You can see they're focusing on adults. Advanced age in itself is a risk factor, immunocompromised, lung and cardiac conditions, but also institutionalised older adults and older adults with functional disability. So these are the targets that we really need to try to get to for the use of our vaccines. And just very quickly, again, looking at some figures down the bottom there that are underlined, compared with the flu in adults over 65, increased length of stay over 7 days compared to the flu, higher rates of exacerbation of chronic lung disease, and increased mortality within 1 year. So if you look at last year's figures, the flu obviously was the most significant by number, but RSV can't be underestimated in terms of its impact in people, particularly over 65. And a lot of words on this slide, but just to say that non-pharmaceutical interventions remain important. We heard that in the last talks on basic infection control practices. Testing, now that it is reportable, it's great we have a better handle on numbers. We heard about some of the limitations of rapid antigen testing and how we don't capture that. And there are combination rapid antigen tests that do include RSV. And management, really there's a lot to say there, but there's nothing really we can do. We can use steroids in people that have an exacerbation of lung disease, but really there's nothing we can do. And that further highlights the importance of prevention. I guess if you compare to flu and COVID, we have antivirals, but at this stage there's nothing that we can use to effectively treat RSV. We've heard a lot about infants, and this is really a huge success story. Still some complexity there, but obviously this has been a great success and really well rolled out in our country. And just to say that obviously part of that is that one of these vaccines is now approved on the NIP for use in the maternal program. And just coming back to vaccines, we had a great introduction to this earlier. It's not like we just started thinking about RSV vaccines. It's something that happened really from almost immediately after we discovered this virus in the 50s. But those early attempts, very crude approaches, I might add, very different to what we do now for designing vaccines, effectively did the opposite of what we want a vaccine to do. We had this concept of enhanced disease, so people unfortunately who received that vaccine who got RSV did worse than those that didn't, and that poor little child on his grandma's knee didn't survive his RSV infection, thought relating to that. But we understand that mechanism. The current vaccines we're using have been specifically designed to get the right type of response, both in terms of this not being the case, but also being highly effective. And Tony introduced the pre-fusion concept as well. Again, this took some time, some very sophisticated medical research here to get to the point of having a stabilised pre-fusion protein, F protein, and that's what's in all of these interventions. That's what's in the monoclonal antibodies we use, but also in the vaccines as well. So we have 2 vaccines that are approved and in use in our country. So GSK or RSV, this is an adjuvanted vaccine, so same adjuvant as Shingrix, and approved some time ago. And the TGA approval at the start of 2024, so that was adults 60 years and older. And then in the middle of last year, expanded out to include adults 50 to 59 with risk factors that I'll highlight in a slide later on. And we've got Pfizer, Abrysvo, which as I mentioned is bivalent, so includes A and B. No adjuvant, also approved some time ago and for 60 years and older, and that's the one that we use in pregnancy. And I'll probably say this many times, they're not interchangeable. So that's the only one that's approved in pregnancy. And if we look at the evidence, and if you believe some, we've never done vaccine trials with placebo controls, but here's some really excellent examples recently where we've done large, really well-designed trials, including large numbers of participants where we did compare to placebo. If you look here, there was 25,000 participants randomised 1-to-1. And these studies showed it was highly efficacious and very safe. The thing I will point out about these endpoints is across the trials for the different products, the same endpoints weren't necessarily used, so it's not right to compare those numbers and say one was 82.6 versus both obviously safe and effective in their own right. And GSK or RSV shown here is not approved in pregnancy. If we look at Pfizer or Abrysvo, this is the bivalent one. Once again, a very large, very well designed and conducted clinical trial, 60 years of age and older, so this is for older adults specifically, about 35,000 participants, placebo-controlled, very safe, highly efficacious as well. In pregnancy, again, not the focus of this talk, but really hard to do clinical trials in pregnancy, and some 7,000 participants enrolled, once again demonstrating it was safe and effective and compared to placebo. And so just a quick timeline of how things have unfolded in our country. So the approval on the 8th of January 2024. This was the first guy to receive the vaccine, 29th of February, I think, in WA he was. And then we saw funding under the NIP for use in pregnancy in February last year. And then we heard about the excellent source of medical information, the Courier Mail, just yesterday. Here it was also published that the expansion of one of these products to include adults at risk, 50 to 59. And then more recently, in the middle of last year, Victoria have added funding in a fairly limited way for one of these products in specific older adults. So there is some funding, obviously not NIP yet, and a concept we'll come back to a couple of times. So we've heard about the MIPP, and this is fantastic, and I just put this here again just to highlight that one of these products is on the NIP already, which is tremendous. In terms of availability in older adults, so again, some slightly complex recommendations, so I'll spend a little bit of time on this slide. So adults 75 and over can get either product, and that's listed as recommended regardless of risk factors. And of course, it's a single dose any time of year, and it does allude to the fact that we try and give it ahead of the RSV season. If you're in that bracket of 60 to 74, again, you can have either product. It's listed as a consider if no risk factors, and a recommended if you do have risk factors, and I'll show those on a slide coming up. Of course, now for a RSV only, eligible for adults 50 to 59. So, but you do need to have risk factors to be in that younger category for that product. And then in terms of funding here in Victoria, from the middle of last year, free for residents 60 and over in public and Aboriginal community-controlled aged care centres. So recognising a number of risk factors of that population, I think it's a fantastic first step. Obviously, we'd like to see that expanded outside of state-based funding for all older Australians to be able to have access to these products. Some of those conditions associated with increased risk, and again, there'll be no surprises on this list, basically cardiac, lung disease, immunocompromising conditions, metabolic disorders, kidney disease, neurological conditions, and other things. So it's quite a long list, so eligibility is quite broad in those groups. Uptake, we don't have good data really yet on proportions that have received this. Some surveys suggest fairly low numbers, but they're a bit old and limited in number. And if we look globally, again, uptake's pretty low still. In Japan, there was a study showing that still less than 5% of people had received it, despite fairly broad eligibility. And a US study published not that long ago suggested slightly higher uptake. I think it was funded in those groups, so about 16%. But they did look at factors associated with uptake, obviously being higher risk, and that included living with more people and having some of those comorbidities that I mentioned, but also people that had received other vaccines were, and not surprisingly perhaps, associated with more likely uptake of RSV vaccines. And I'll come back to this concept of co-administration, but if people are having those other vaccines, they may be more accepting of getting an RSV vaccine, and you can do that potentially at the same time. A lot of challenges still with RSV vaccines in older adults, the funding issue, and in this current climate, the out-of-pocket cost can be a significant barrier. Although some feedback at some GP meetings has been not to assume that people can't afford this product, especially if they've had an experience with RSV, seen someone get sick from it, even though it might be seen to be a bit of a stretch, they still may be willing to go ahead. It's a more challenging landscape than ever before with vaccination in general, and so obviously we're dealing with that with RSV, but I think also an underappreciation of the significance of RSV. A lot of people don't really understand it's right up there with the flu and COVID in terms of what it can do, and therefore worthy of taking steps to reduce that burden. The groups in which we're using this vaccine are getting increasingly complicated. So for old adults, we're really lucky. We've got all these extra vaccines available, and it's more complicated. Enhanced vaccines for the flu, frequent recommendations for COVID, for example. So it can be a bit overwhelming for people to know what they're eligible for. And so making sure we check that and give people what they're eligible for when we can. The fact that they're not interchangeable, there's been, and we heard some of this in previous talks, a lot of mix-ups of some of these vaccines, so we need to make sure we're giving the right one to the right people. And a question we often get asked is there going to be repeat dosing? And the simple answer there is we still don't know for sure. I don't think any of us expect this to provide lifelong protection. There may be the need for boosters down the track, but we simply don't know what that interval looks like just yet. So just some practice points. As I mentioned, there is some funding of these products. Nirsevimab funded on a sort of state-based program. We know that one of the vaccines is funded in pregnancy on the NIP, which is fantastic. Victoria have that very limited funding for really high-risk people, but otherwise it is still currently private for older adults. Co-administration, as I mentioned, studies suggest if people are getting non-RSV vaccines, they're more likely to want an RSV vaccine. And there was a recent large study looking at the adverse event reporting system from the US that showed there was no significant increase in adverse events when given, even if COVID, flu and RSV are given all at the same time. And we need to make sure, as I said, that we don't mix them up. Just very quickly, I'll fly through some new vaccines. We've already seen these path slides. For older adults, there's not really a big change, but the main change is MaxVax is now in phase 3, another subunit vaccine, but there are still a lot of candidates coming through. Had an excellent talk on mRNA already, and obviously Moderna have an mRNA COVID vaccine approved by the FDA mid-24 and actually approved here last year. And you can see there a little study we did was back in 2016, so once again not new technology and really lends itself well to things like RSV, and of course sets the stage for combinations as well. And the PATH slide showed there's quite a few combinations in various stages of clinical trials. The AstraZeneca Icosavax, RSV and human metapneumovirus is in phase 2. There's quite a few in phase 1, including RSV, human metapneumovirus and even para-influenza. So these combinations are hopefully going to progress well and may become an option, but once again, not necessarily the solution to all of our problems, and timing of how we use these might be a bit of an issue. So just wrapping up, I think I'm nearly on time, Rod, sorry. So hopefully I've been able to convince you that RSV is a very significant pathogen, particularly in young children, but also in older adults. No specific therapy, so I have to highlight the importance of prevention. We've tried to make RSV vaccines for a long time. It was really tough, but now we're there and we've got some fantastic products that are available, not yet funded. That's obviously a big limitation on how we use them, but certainly available. And I really look forward to seeing the impact they're going to have as we expand their use. And watch out for combination vaccines. There's been lots in trials in our country, and hopefully some of those will progress all the way through fairly soon. And I'll leave it there. Thank you.
Thank you, Paul. I've got a question. You did touch on it. How long are they lasting? People are saying 3 years probably. You can put your money in 3, 4, 5, or...
As always, we need to answer these questions with the data that we have available, and we have excellent durability over a number of years. Exactly how long that will be before we need to look at redosing still does remain to be seen. So, I don't think it's going to be one dose and never again. I think there'll be the need for boosters, but we'll watch this space.